Hello, everyone. My name is Josh. I'll be moderating the event today, and thank you guys for showing up tonight. I know it's a little late. You've been through a long day at clinic, but we certainly appreciate you attending today. So a couple housekeeping pieces before I pass it over to Dr. McMillin here. The main thing for everyone here is if you have any questions on what's being presented today, on the GoToWebinar, the pull-out side menu there, you'll see a tab that says questions. If you have any questions, please feel free to put those in that tab there, and we'll go ahead and review those at the end of the presentation and get all of your questions answered. So without further ado, I'm going to pass this over to Dr. McMillin and start the presentation.
All right, thanks, Josh. So this is sort of the initial set of a series of educational webinars we're going to do, hopefully to, sorry, I lost my, good. So this is just a series of educational webinars that we're going to do, hopefully to share some knowledge with our community here in East Tennessee. Hopefully we can work together to take care of our patients and kind of provide some of the best care that we can. So we're grateful that you're here with us. And I'm going to talk about something today that I'm really interested in, that I care a lot about, and that is corneal edema and how we manage it. Things have changed a lot in the past few years. I think somebody's got their mic on. Make sure we're muted. But things have changed a lot in the last few years in terms of how we manage corneal edema. And so we're going to go through all of that. All right, so kind of the objectives of the presentation are just to look at the pathophysiology of corneal edema. We're going to discuss the differential diagnoses, take a look at Fuchs dystrophy and kind of how we stage it. Also look at tomography and how that plays a role in our early diagnosis of corneal edema. I'm going to highlight the various types of endothelial keratoplasty, the pros and cons, why we use different ones, and then just expand on kind of the future, what I see going forward in our field. So when you think about corneal edema, you really have to break down the epithelium and think about how it's structured and the polarization of the tissue. So, there's certainly a basal side and an apical side, and the apical side is basically blocking the external environment with tight junctions. Those tight junctions are preventing any sort of fluid or pathogens from entering the cornea, and that is really helpful in preventing corneal edema. So anytime you have a break in the epithelium, you can develop corneal edema. Same thing goes for the endothelium. We've got desmosomes on the basal side that are essentially a barrier to fluid. And if you have a break in the desmosomes there, you can also get edema of the stroma through the endothelium. So we have kind of primary, secondary etiologies. The primary etiology, somebody has their microphone on, so everybody just needs to mute their microphone. That'd be helpful. All right, so some of the primary etiologies are things like corneal dystrophies, most commonly Fuchs dystrophy. That's what we see the most in clinic. We also see things like posterior polymorphous dystrophy sometimes, occasionally ICE syndrome. The secondary things that we see are things like chemical injuries, trauma, corneal abrasions, post-surgical. Those can all lead to corneal edema. If you have a normal endothelium, you can have elevated intraocular pressure post-operatively or due to like acute angle closure that can cause edema, and then just epithelial failure and epithelial defect. So any of these things can cause edema, and so you have to think about what is the underlying etiology and why is it occurring. So we want to identify and treat the secondary causes because those are the easier things to deal with. So if you have elevated pressure after cataract surgery, we want to think, is that just retained OVD, a pressure spike from that, or is this something like a retained lens fragment, maybe even reactivation of a herpetic cause like simplex or shingles. Uveitis can certainly cause edema, kind of a raging anterior segment. Uveitis can cause it, an epithelial defect. Medications like dorzolamide, even just topical dorzolamide can do it. Amantadine, which is a medication that is also often used by the neurologist, can cause edema, bilateral edema in the PO form. Wellbutrin can do it. Anything that has BAK, so really any topical drop can cause corneal edema just from a BAK reaction. We've all seen tight contact lenses and ischemia, so things like an ophthalmic artery occlusion or ocular ischemic syndrome, those can all lead to corneal edema as well. So a lot of varieties, you really have to think about where it's coming from. So this is a patient that presented about 3 weeks after cataract surgery, referred for persistent corneal edema. Any time you see edema in that inferior wedge, kind of 5 to 7 o'clock, you want to be thinking, if it's post-surgical, where's the lens fragment? Because that's where it's going to be. So put a gonio lens on the eye, and often you'll find it. You want to catch these early because they're a pretty easy fix, quick fragment removal, and the endothelium should recover. Now, I've seen these patients go months and months and have endothelial decompensation and need a DSEK or a DMEK. So we want to catch these within that first 6 weeks or so, and they usually do just fine. This was a patient referred to me for a new onset of bilateral corneal edema. Patient had Parkinson's, reviewed his med list, and he was on amantadine. So we contacted his neurologist and got him off amantadine. And this is a really easy catch. You just have to be aware of the medication and what it can cause. You get the patient off of it, can really, the patient thinks you're a hero, and it's a really easy thing. You just have to be aware of the side effects of the medication. When we think about edema, we have to talk about Fuchs dystrophy, because that's the one that surgically we certainly deal with the most. It's been described over 100 years ago by Fuchs, one of the great ophthalmologists, and it affects about 4% of our population. So we all see it on a daily basis in clinic. It typically worsens with age, and we see it more commonly in women. And there is actually a genetic component to it. So we've isolated it's a trinucleotide repeat, and the more repeats patients have, the earlier they develop it, much like Huntington's disease or any other trinucleotide repeat condition. They present in the 40s to 50s. We see this is a nice retroillumination photo of a patient with Goutte. The Goutte alone, even without edema, can cause significant glare. I've had a lot of patients with sort of 20/30 vision, no other reason, and they have a lot of glare, and it's the Fuchs. That alone can cause a lot of glare, even when there's no edema present. Stage 2, we start to see the Goutte migrate outside the central 4 millimeters and start to affect the peripheral endothelial cells. And somewhere in this stage is where we start to see some endothelial decompensation. And it's not always clear exactly when the decompensation occurs, because stromal edema can be very, very subtle. Often you can't see it, you can only measure it in form of pachymetry or some sort of tomography. When the stromal edema worsens, you usually develop microcystic corneal edema, and that's really when patients present with reduced visual acuity and significant glare. So that will bring them into the office if they haven't previously been identified. Stage 3, these are the patients that come in with pain. Bullous keratopathy, the bullae can rupture, they develop pain, and we really want to prevent patients from getting to this stage, because these are the patients that can develop subepithelial scarring. And once they can develop subepithelial scarring, it becomes, the patient in the bottom right of the screen probably is not a good candidate for an endothelial keratoplasty because of the scarring. So unfortunately, that patient has sort of gone too far and might have to be rescued with a penetrating keratoplasty or a full thickness transplant. So really, we want to prevent patients from getting to stage 3 if we can. The longer they have edema, and once they've had bullous keratopathy for more than 6 months or so, there's going to be some scarring. Just because they have bullous keratopathy doesn't mean that the scarring is visually significant, but that's when it starts. I've seen occasionally patients referred for recurrent erosions, and they actually have bullae from swelling. So the problem really here, at least the clinical issue, and the problem that I have is that I'm not good enough to detect edema at the slit lamp if there's no symptoms and there's no haziness to the stroma. And so we can use tomography, and in our practice, we use the Cunningham to evaluate some subtle changes to the cornea and try to predict those patients that have Fuchs, that have early swelling, and who might go on to develop corneal edema if they were to have surgical procedures or something like that. So there's really three key features on the Cunningham that we look at. So we look at isopachs. We all know about isopters from Goldman visual fields. And so we look at isopachs. So these are rings of pachymetry presented on the Cunningham. We also look for the thinnest point and look for it to be displaced nasally. We also look for focal posterior depression. So when you think about the cornea in 3D, we're thinking about the cornea expanding posteriorly into the aqueous, and that's sort of just like an early thickening of the posterior stroma that can be detected. So here's a patient from 2012 in the top two images. And so what you can see is that there's these isopachs, and these are regular rings, and the warmer the colors, the thinner the cornea. And you can see that it's nice and round, and then it starts to lose that shape and becomes more D-shaped here. And that's a very, very subtle loss of a regular isopach. And this round dark circle is the pupil, and then the thinnest point has been just slightly displaced nasally. Now this is the posterior float, and any negative number means that it's thickening posteriorly, and a positive number means that it's elevated anteriorly. So here you can see in the middle of the cornea, this -2, and that's just a really subtle posterior float. Fast forward 7 years, and you can see even more pronounced loss of the regular isopachs, and that's really pronounced. This patient probably has some stromal swelling in this area of the cornea. And when you look at the posterior float, you can see this -21. That patient has a lot of posterior thickening, and this patient is definitely at risk for corneal decompensation in the future, especially if they have an intraocular procedure. So how can we use that information? So those are three risk factors that I like to look at: the isopachs, the thinnest point being displaced, and posterior depression. So if they have none of those risk factors, and we do phacosurgery, there's only a 7% risk that they're gonna at 7 years have corneal edema. If they have one or two risk factors at 4 years, they're about half of them will have it. And if they have all three of those risk factors, 90% of those patients will swell within 4 years of surgery, requiring an endothelial keratoplasty. So this is a graph showing just that. So if you look at the red line, you can see that this is the 0 variables. So obviously none of those developed edema. The green line at 48 months, 50% of those, one or two of those variables were positive, had swelling. The blue line at 4 years, 75%, and at 5 years, almost all of those patients had swelling. Other non-specific metrics that we look at regularly. So pachymetry, that's helpful. If you have a handheld pachymeter, or you can measure it with an anterior segment OCT greater than 640, that can be helpful. And then the endothelial cell count of less than 1,000. So those are other metrics that we look at. Helpful yet not definitive. So just additive information, sort of things to help you build a case for which way you're going to take a patient. When we think about medical therapy for these patients, Muro can help. And in some patients, it doesn't help at all. But the patients that it helps are patients that have microcystic edema. It's not as effective for a lot of stromal thickening, but the microcystic patients it helps. It can definitely improve comfort. And the patients that have this kind of diurnal pattern of symptoms where it's worse in the morning, gets better in the evening, those patients tend to do better with Muro. If they've gone on to Frank Boule, Muro is sort of a little too late, but it's certainly something that patients can try, and it's always nice to have a medical option to offer patients before we go on to surgical options, even if it just buys them some time to kind of deal with making that kind of decision. So I always offer patients medical therapy, no matter how severe it is, even though if I know it's not going to necessarily fix them, because it's helpful to give them, a little bit of time to think about that surgery. So why should we do surgery for corneal edema? If you have a symptomatic decrease in best corrected visual acuity, or you just have glare symptoms that interfere with the ADL. So it's much like a cataract patient. So, if a patient's worse than 20/30, and they have and they're really having a lot of issues, then those are the patients that I start to think about surgery for. The later indications are patients that present with bullous keratopathy and pain. I want to see patients way before they get developed bullous keratopathy and pain, and hopefully prevent them ever developing that chance for scarring, chance for infection, and just having to deal with, suddenly showing up at the doctor's office with their eye swollen and pain. The ideal patient for surgery, has visual acuity that's maybe in the 20/40, 20/50 range, some stromal edema, blurred vision, but hasn't yet progressed to a bullous keratopathy. I think these slides are really interesting. This came from the Eye Bank Association of America. This is going from 2005 to 2019 and looking at the trend of keratoplasty in the United States. And this is based on, tissue that they distributed to surgeons. The blue line is full thickness corneal transplant. So you can see that in 2005, we did roughly, 42,000 PKPs. In 2019, that number was less than half of that, 17,000, something in that range. But if you look at EK, which is DSEK, DMEK, or any variation of one of those procedures, it was practically zero in 2005. And as of 2019, we did about 31,000 endothelial keratoplasties. So endothelial keratoplasty has really taken off, and it's really lowering the burden of penetrating keratoplasties, which is a great thing for patients, and it's a great thing for surgeons and for the community because, as we all know, PKP patients, they can have a lot of long-term issues. Sometimes they do great, sometimes they have other issues. And so while it's a great procedure, we definitely, if we can minimize the amount of PKPs we're doing and rescue people with endothelial keratoplasty, it's a great thing. If we look at it a little bit deeper, and let's look at DSEK versus DMEK, right? So this on the y-axis you have, this is in this is in thousands. So you can see that the red line is DSEK, and the blue line is PKP starting in 2015. And they were roughly equal in the amount of DSEKs and PKPs we were doing about 6 years ago. The new one is DMEK. So 2015, you can see that there was just a few DMEKs, and as the DMEKs have climbed, PKPs have remained about the same. DSEK has decreased, and we're going to see DMEK overtaking DSEK in the coming years. So here's just kind of outlining those numbers. 2013, we did about 25,000 endothelial keratoplasty procedures. For 2013, only 1,500 were DMEK, and 23,000 and some change were DSEK. In 2019, we did about 13,000 DMEK and about 17,000 DSEK. So I think we're seeing the overall number of endothelial keratoplasty climbing because the indications are becoming broader. We can do surgery on people that have less severe disease because we're expecting better outcomes. Also, we're replacing many of our DSEK patients with DMEK, and we'll go over why that is. So our current techniques, Mellis described this in 2004. DSEK is a larger lenticule of posterior stromal tissue and endothelium. And depending on who's doing the procedure and why they're doing it, a DSEK can be as thin as 60 to 70 microns, and we call ultra thin DSEK. Traditionally, a DSEK is usually about 120 microns. Now, DMEK is only about 15 microns. It involves the endothelium and Descemet's membrane only. So big difference there. Descemet stripping only, or DSO, was described in 2016. Now that's a procedure where we're just stripping out guttae and leaving it and allowing the peripheral endothelial cells to migrate into the gap and clear the edema. And we'll talk a little more about that. So now DSEK, why are we doing DSEK if DMEK is better? DSEK still has a really important role in our kind of surgical toolbox. And I love DSEK for patients who have hardware in their eye. So if they've had an OMED valve or a Barreveld, if they've had a TRAB, if they've had a pars plana vitrectomy, maybe a sutured IOL, if they're aphakic, if they have significant iris trauma and defects, those patients do really well with DSEK. That's a great procedure for those patients because DSEKs adhere to the posterior corneal stroma easier than DMEKs. And so in a complicated eye, I want to throw my fastball and make surgery easy. And so I go for a DSEK. DMEK is the procedure I prefer to do because the visual outcomes are better. But those are patients that really have normal anterior segments. So they can be phakic or pseudophakic, but they don't have hardware in their eye. Their eye is going to act normally because it's going to have vitreous in it. I don't want an eye that's had the vitreous removed because then the AC gets very deep and it becomes hard to unroll the tissue. And so, DMEK is really for our Fuchs patients or PBK patients, patients that haven't had really any other surgical manipulation of the eye, which turns out to be a large majority of our patients. This is a great anterior segment OCT. You can see the DSEK lenticule attached to the posterior stroma, and you can see that there's the kind of the host posterior stroma that gets this sort of hyperechoic line, and then the DSEK lenticule, you can see it's been cut here, and it adheres to the posterior stroma. That works really well there. This is a DMEK, and now I've purposely showed you a DMEK that has a small detachment of the Descemet's membrane, and it's a little bit rolled up here, and you can see that. But I wanted to show you that so you can see just the difference in thickness. So what has made DMEK easier since it's come along? So, initially DMEK was considered to be a lot more surgically challenging to perform, and it is, I think, maybe a more challenging procedure in a lot of ways, but we've done a lot of things to make our lives easier. So gas bubbles, initially we were using air, now we're using gas. It lasts longer, prevents detachments. We're using tissue that's prepared by the eye bank, so we're not having to strip and prepare our own tissue, so it comes preloaded in a glass tube. We're stamping the tissue with ink so we know which side is up and which side is down. We use something called an S-stamp. And then we rebubble with a slit lamp. So whenever there's a detachment, we do it in the exam lane. We don't have to go back to the OR. It's fast and saves patients a trip to the OR, and we're able to take care of a lot of things in our clinic. I also do a laser peripheral iridotomy to prevent bleeding during surgery by doing a manual iridotomy. This is an example here of a patient one day after a DMEK, and you can see the inferior peripheral iridotomy. This is to prevent pupillary block from the gas in the eye, and to allow aqueous to communicate with the posterior and the anterior segment through the PI, since the pupil is completely occluded by the gas. Here is an example of how I get the tissue from the eye bank. So the blue stained tissue is the DMEK, and that is loaded into a container with Optisol, which is a pink fluid that is a tissue preservative. So we use it for all sorts of tissues in organ transplant, but the tissue can live in that for several days and not have any degradation of the quality of the tissue. We take that little glass tube out of the container and attach it to a syringe for injection into the eye. This is an example of the S-stamp. So this is a little slit lamp image, and so you can see it's on the posterior stroma. Sometimes you get a little edema around the S-stamp the first couple of days, and you can see there's a little edema over the S-stamp there, but that clears. And I know that it's in the right side. If I see that S, it stands for smart and not stupid, and I can see that my S is in the correct orientation. S is one of those letters that if you flip it over, it's backwards. So we're looking for an S that's grammatically correct here, and you can see it. It actually can persist for months and months afterwards. When you see these patients, you can see that ink mark. I was talking about Descemet stripping only earlier, and so this is sort of an interesting thing that's coming forward. Catherine Colby in Chicago brought this up about 6 years ago, and in her initial case series, she had 13 patients that couldn't have or didn't want to transplant for various reasons, and she stripped the central 4 millimeters of guttae. About 40% of patients within a month actually cleared. Another 40% took 3 months, and 20% of those patients took 6 months to clear. 3 of them did not clear at all and required a DMEK or a DSEK to rescue. Things like Ropressa, these ROCK kinase inhibitors, are added during this procedure topically afterwards, and that's thought to enhance endothelial cell migration to cover the defect. So there may be a role for this surgery in some patients. The recovery with DMEK and DSEK is so much faster that not many patients are really interested in this. But I do think there's a role. What I think it tells us mostly is it tells us a lot about the corneal endothelium and its ability to migrate. It's pretty incredible that it will clear like that, and I'm not sure any of us thought that would happen. But I think this is maybe a stepping stone to future procedures. Here's an example from her paper of she strips the central 4 millimeters and then allows restoration of the endothelium to grow in. And using Rho kinase inhibitors, again, enabled some migration of endothelial cells. Now, this particular paper was also talking about using cultured endothelial cells. So the folks in Japan are culturing endothelial cells in the lab, and then stripping Descemet membrane and injecting endothelial cells into the eye, laying the patient face down post-operatively for several hours and allowing the endothelial cells to essentially sink down like a snow globe and adhere to the stroma. And they're having really good results with that. And so the hope is that in the future, we may not have to do DSEK or DMEK, and maybe we'll be injecting corneal endothelial cells that are made in the lab, and those will, sort of magically adhere to the areas that we've stripped and clear the cornea. So there's a lot on the horizon in terms of those types of patients. Here's an example from that paper out of Japan. So stripping, laying the patient upside down, and allowing those endothelial cells to adhere and repopulate. All right, so right now, endothelial keratoplasty is really the gold standard for cornea transplant for corneal edema. DSEK patients at 6 months, the average best corrected visual acuity is somewhere in the 2040 or 2030 range. And we'll see about 10% of our patients that can be refracted to 2020. With DMEK at 6 months, the average best corrected acuity is somewhere in the 2025 range, and about half of those patients will reach 2020. Now, there's certainly a wide variety, but it's surprising to see a DMEK patient that can't be refracted to 2040 at least. They definitely show superior contrast, sensitivity, and subjective vision. I've had quite a few patients who have had DSEK maybe 7, 8 years ago, and then they have DMEK in the other eye. Regardless of what the best corrected vision is, and even if it's the same, they will prefer the DMEK eye. Now, this is a patient that is, I think, about 2 days after DMEK, and sometimes they can be amazingly clear with that gas bubble still in the eye. So DSEK, really, it's an easier surgery for the most part. The tissue prep is a little easier, but the visual outcomes, there's less rejection. Patient satisfaction, I think, is better with DMEK, and the endothelial cell loss is the same. All of these patients will lose some endothelial cells during the transplant, so that's sort of a wash. So we're doing DSEK, like we talked about earlier. If they've had endothelial failure, we can rescue PKPs. So if there's an old PKP from 20 years ago and it fails, we can do a DSEK underneath that and not have to repeat the PKP. And so that's a great option for salvaging old grafts as long as there's no corneal scarring. Post-vitrectomy, previous glaucoma surgery, over top of an ACIOL. If you have patients that are just traveling a long ways for surgery and they can't tolerate the slit lamp, those are patients that we will do a DSEK in because there's a lower risk of needing a rebubble. DMEK is more likely to need to be rebubbled within the first week or two. And patients that generally have a lower vision potential, DSEK is easier. You can do a DSEK if you know the patient, there's no way the patient's going to be 20/40 or better, then do a DSEK because it's easier and less likely to have need a rebubble post-op. This is a patient of mine that had a PKP, and you can see that while they have peripheral corneal neovascularization, the central PKP button has no scarring. And so I've placed a DMEK or a DSEK. You can see the edge of the DSEK. There's gas in the eye right under there, and that rescued that graft, and that prevented the patient from needing another penetrating keratoplasty. This is a patient who had had vitrectomy 3 times and had large iris defects. This is an iris suture that has sort of cheese wired, and we were able to restore his vision with a DSEK. Post-operatively, whether it's DSEK or DMEK, they're all going to be on their back, staring at the ceiling for 24 to 48 hours. And we give them about a 20-minute break every couple hours. Patients are super creative. I've had patients put projectors on the ceiling, listen to audiobooks, all kinds of things to sort of manage the boredom that inevitably occurs post-operatively. But there's lots of things they can do to sort of get comfortable. And I just tell them, you know, the surgery is half of the battle, and really half of the work occurs with the patient after surgery being really, really compliant. So that's a really important topic that we discuss with patients in detail. I start with prednisolone acetate 1% every 2 hours for the first week. Then I taper it down to about 4 times a day for a month, and then I go down by 1 drop each month, and then I'll transition them to a low-dose steroid like FML or Lotemax indefinitely. It's been several years. Sometimes we'll discuss taking the patient off of steroids even if there's like glaucoma or a pressure response issue, we'll do that. And I just do Vigamox for a week post-operatively. I see them day 1, 5 days, a week, and then a couple months out, we start spacing those out. This is something that our patients find super helpful. We actually keep these in the optical shop. They're just prism glasses, so the patients can lay down flat. This guy is doing a great job taking care of his transplant and watching TV at the same time. So those are super helpful. Anything I can do to keep a patient on their back with their eyes facing the ceiling, that's what I'm going to recommend to them to make sure that we can limit the need for a rebubble. So complications of grafts. Most common is about 30% plus or minus may need a rebubble, and the numbers are all over the place, and it depends on really the patient. The more complicated the patient, the more likely they're going to need a rebubble. The worse their positioning, you know, I think the rate is probably lower than 30%, but in some, especially the early papers, it was reported to be about 30%. Now, if it involves more than 1/3 of the cornea or it's in the visual axis, I'll rebubble it and perform that in the office. Here, this patient is clear superiorly. Inferiorly, they have microcystic edema, they have a detachment, and so we rebubble them in the clinic. I will hook up some IV tubing to a 30-gauge cannula, and I'll use that 30-gauge cannula to enter the eye through a pre-placed inferior 1 millimeter paracentesis incision that I placed in the OR for this purpose, and just slide in there using air, room air, and rebubble the transplant and then lay the patient back. This is a anterior segment OCT of a patient 1 day after surgery. This patient, amazingly, was 20/70 1 day after surgery. His gas bubble was smaller than I wanted. That's why normally they're hand motion because they have a gas bubble, but his gas bubble was smaller than I wanted 1 day after surgery. It probably leaked some air overnight. His DMEK was completely attached. You can see the kind of hyperechoic line on the OCT, and he was doing great. He came back at week 7 or day 7 and said, you know, I'm just not seeing as great as I was earlier in the week. You know, what's going on? And I did an anterior segment OCT, and you can see where he's detached. It's sort of bowstringing. That's the transplant. Super, super thin. It's attached here and it's detached here, and you can see the stromal thickening. I rebubbled him in the clinic, and this is day 10. 3 days afterwards, he's completely attached, and he was 20/30, which for 10 days after a cornea transplant is just really remarkable. I think that we're all incredibly fortunate to be practicing ophthalmology and cornea surgery this day and time, because this sort of outcome just wasn't even fathomable 10 years ago in our field. So, you know, just a testament to the folks that are developing these techniques. It's really amazing. Primary graft failure. This is super uncommon. I haven't seen this often, but it can occur. These are patients that you do surgery. Surgery is perfect. They are attached. You don't have to rebubble them. They don't have any signs of rejection, but the cornea transplant never clears. And it can happen for a couple reasons, but usually it's because the tissue was poor. The tissue did not survive harvesting the tissue, processing the tissue, and surgical implantation in the eye. Sometimes surgery is really difficult, and that can maybe damage the tissue, but I've had rather difficult surgeries in the past, and the tissue is cleared. So I think when you get a primary graft failure, there's a problem with that tissue, and it has to be replaced. Now, this is one of the scary ones. This is a patient that has a beautifully looking clear transplant, and they start to develop these little white crumb-like opacities in the interface. And in that interface, those little opacities can slowly increase in size. When you see this, it seems like not a big deal at the time because the patient's seeing great. That transplant has to come out. The patient has to have injections of antifungals in the anterior chamber, and you have to be super aggressive because once fungus seeds the intraocular contents, it is really, really difficult to get rid of. And so this is one of those complications that you just never want to see. I've never personally seen one, but what we've started doing is getting our tissue transported in the media with amphotericin in the storage media because I am terrified of a fungal interface keratitis and I don't ever want to see one. So we've added the amphotericin B to our transport media to try to prevent this because patients can actually lose vision because of sort of uncontrolled fungal spread into the iris. It seeds the iris. It can get into the capsular bag if they're pseudophakic, and then a posterior segment. It can be really, really challenging to get fungus out of the eye. Graft rejection. So we see graft rejection commonly in PKP patients. About 20% of PKP patients will have an episode of rejection in 5 years. With DSEK, we see it a little more commonly, and about 1 to 3% of patients will have a rejection at some point with a DSEK in their lifetime of having that graft. DMEK, it's probably less than 1%. It has to do with the volume of tissue that we're transplanting. Usually, it's with DSEK and DMEK, it's not a red, hot, painful eye. It's some KP, maybe a little bit of corneal edema, blurred vision. So patients will usually present with just a complaint of blurred vision. They don't complain of pain, they don't complain of photophobia, and so I'm always checking for cell, any amount of cell, and I want to make sure that I'm treating and making sure that it's not early rejection. But luckily, these patients do well. You can hit them with Durezol or subconj injections of Kenalog, and they can turn around pretty fast. So this is a video, kind of a quickly edited video of a DSEK, and so here I'm preparing the tissue. I'm splitting the interface between the stroma and the DSEK. I've loaded it into something called a booz and glide, and I'm kind of folding it into kind of a burrito shape. I'm going to flip it over and pull it into the eye, and you can see the little AC maintainer there. I use a special forceps to get it into the eye. I'm going to suture my incision and then go under the DSEK graft, and you can see it's sort of like a frisbee in the eye. It's one solid piece, and then we put the gas bubble under it, and you can see a really nice outline of the transplant there. Keep that patient on their back for an hour or two in the post-operative period, then we send them home with strict instructions and see them back the next day. Now that was a DSEK, so let's show you a DMEK. So this is a DMEK. We've just stripped Descemet's membrane. So that's Descemet's membrane. I've stripped it off the central 8 millimeters that I've marked on the cornea with the dots, and I'm pulling it out of the eye with a forceps. Now I've constricted the pupil so the transplant stays in the front of the eye. And here I'm going to inject my transplant through the glass tube through a 2.5 millimeter incision, same size incision I use for phacosurgery. It's important that we shallow the eye. We keep the eye pressure really low. I suture my wound, and then I only touch the tissue on the outside of the eye, and I use fluid currents and pressure to unroll this tissue. Now, Descemet's membrane has some memory, and it wants to fold up and roll up, so we have to sort of pin it. So here I'm trapping one side of the transplant, and I'm creating fluid currents by tapping on the cornea to unroll the tissue. Now the tissue is unrolled, and I'm going to place a nice fluid bubble just right underneath the transplant. You can see that S stamp, and there we go. So we're going to put about a 60 to 80% gas bubble. I use diluted C3F8, which is the same thing the retina guys use, and it can last about a week for me. And that really reduces the rate of rebubbles by using that gas. So couple take-home points. DMEK provides the best visual outcome in healthy eyes. There's still a really important role for DSEK, and PKP is only indicated for severe disease or stromal scarring. So also tomography, if you have it available, that can be really helpful in identifying subclinical corneal edema. And Fuchs may be treated in the future with cultured endothelial cells. So that's going to be awesome. I think we're probably going to see that. That's going to greatly expand the ability to provide transplant around the world to other patients. Now, we're super lucky in the US. I can order a cornea transplant tissue like I can order an IOL. I just contact the eye bank and I can almost always get a transplant. It's not the case internationally. We have a surplus of corneal tissue, and in most countries there's a waiting list for corneal tissue, and it's really difficult. So cultured endothelial cells may take instead of being able to treat one patient with one donated cornea, we may be able to treat hundreds of patients with one donated cornea, which is just an incredible thing to imagine. So hopefully we'll get there in the next 10 years or so. I would hope. If we intervene early on Fuchs patients or bullous keratopathy patients, we can usually achieve excellent outcomes with endothelial keratoplasty. All right, so a couple kind of post questions. So the first is, what is the difference between DSEK and DMEK? So DMEK has better visual outcomes. That one is true. DSEK is thicker than DMEK. That is also true. And DSEK is preferred in complicated anterior segments. So all the above is true in that case. All right, so when we're looking at tomography, what are the three identifiers of early corneal edema? So the first is the loss of the isopax. So we're looking for that loss of that nice round shape, nasal displacement of the thinnest point of the cornea, and posterior depression. If you have that in your clinic and you're wondering if a patient's going to develop edema after cataract surgery, if they have all three, they're going to get it. And those patients are patients we talk about combined procedures with. Sometimes we don't do a combined procedure, but it's just helpful to counsel the patient. You've got these risk factors. We're going to do cataract surgery, but hey, this may happen. There's a good chance, and we can give patients a sort of a percentage or an idea of what to expect in the future, and that's super helpful in terms of guiding those patients. So the published rate of rebubble for DMEK, it's about 30%. I think that's pretty high. I think that was probably a lot of that data is before we've changed some of our techniques, before we were using gas. I think it's probably, in the 10% range or something like that. I counsel all patients to expect a rebubble, and I tell them that it's not a huge deal. Sometimes it's just part of the surgery, and sometimes it takes 2 gas bubbles. They just need a longer gas bubble, and patients tolerate it really well. I've never had to take a patient back to the operating room to rebubble them. I'm always able to do it in the clinic. I suppose there are some patients that may need to go to the OR if they can't, they're super nervous or something, but for the most part, those patients do really, really well. True or false? DSEK can be performed for failed PKP. This one is true, and I love this indication for DSEK. If we can salvage a PKP, it doesn't matter how old it is. If we can keep that patient's PKP and not open up their eye, basically expose them to all the risk of additional PKP, then we can repeat DSEKs over and over in failed PKP eyes, and they can do really, really well. All right, so thanks for attending tonight. I hope that was really helpful. There's a couple pictures of my kids, and then a picture of me and one of my best friends after he taught me to do cataract surgery. So if there's any concerns or questions you guys have, if anything comes up along the way, please feel free to contact me. I think most of you have my phone number, my email address. We're really passionate about taking care of patients with cornea problems. And we want to try to, share that knowledge with you guys and help you take better care of your patients. And so please feel free to get in touch with us, anytime to talk about patients.
Awesome. Well, thank you, Dr. McMillin there. Great presentation, and I will open it up if anybody has any questions. I don't see any in the question tab yet, but if you have any questions, feel free to type that in now and we'll get them answered. Looks like you did a pretty good job covering the questions, getting everything covered.
Well, so we're going to be doing a series of these webinars, and hopefully, providing some educational content to all the folks here in East Tennessee that are taking care of patients. And, if there's a topic that you would like to see us cover, please let us know, because we want to provide content that is relevant, that is helpful, and that can help you take better care of your patients. And so, please let us know, and hopefully this is going to be a good thing in the future for our community.
Awesome. Well, thank you everybody for attending. We'll be sending out an email afterwards and coordinating the COPE credit there with you guys and be reaching out. So everybody have a great night and enjoy the weekend. Thank you, Dr. McMillin.
Thanks, Josh.
Have a good night.